Hello, everyone. I'm Surbi Sadana from Stanford University. And on behalf of my co-authors, it's my pleasure to give you all a summary of our abstract on real-world outcomes with idacaptogene viclucil or ide-cel CAR T-cell therapy for relapsed refractory multiple myeloma. We did this study using the CIBMTR registry. As you all might be familiar with, ide-cel was the first FDA-approved CAR T-cell therapy that was approved for patients for standard of care use after achieving at least 4 prior lines of therapy. And the CIBMTR registry is a well-established international registry that collects data on patients undergoing cell therapies, including ide-cel. And so the objective of the study was to evaluate the effectiveness and safety of standard of care ide-cel using CIBMTR registry. And this is important because we have data from clinical trials, but patients who participate in clinical trials are usually fit and have to meet a lot of eligibility criteria. And many patients who we see in our clinics actually would never meet those eligibility criteria. And so we wanted to look at the outcomes of this cell therapy in patients we routinely see in our clinic. And we looked at patients who were followed in the CIBMTR registry. These are patients who were treated in the United States and had at least one follow-up that is typically done at day 100. We had 821 patients, so that's a lot of patients. For context, in the KarMMa trial, there were only 128 patients that led to the FDA approval of this therapy. And the median follow-up of these patients after CAR T was almost 1 year. And the primary outcome is looking at effectiveness of this therapy. And we also looked at safety and side effects as secondary outcomes. So what did our 821 patients look like? A third of our patients were above the age of 70, 79% of patients were white, 15% of patients were Black or African American. 77% of patients had a clinically significant comorbidity. And what this means is they had either heart issues or lung issues or other underlying diseases, many of which would never have made them eligible for the clinical trial that led to the FDA approval. 27% of patients had high-risk cytogenetics. When we look at prior treatment history, median prior lines of therapy was 7, so these patients were very heavily pretreated. And 18% of patients had had other BCMA therapies, primarily belantamab mafodotin, which is an antibody-drug conjugate. When we look at effectiveness by looking at response rate, 73% of patients responded, including 56% of patients who achieved a deep response with very good partial response or better. When we look at overall response rate and complete response rate, patients who had high ISS stage disease, which is more aggressive disease, had lower response rate, including complete response. Patients who had poor performance status, that is measured by ECOG, had lower response rate. And if patients had prior BCMA therapy, they also tended to have lower complete response rate. When we look at outcomes from survival, progression-free survival, which is time to progression or death from another cause, was about 9 months median. And this is very comparable to clinical trial data. Overall survival has not yet been reached, and the 1-year estimate is 67%. When we look at subgroups, not a surprise, patients who had higher risk cytogenetics, they had lower survival rates. And this is similar to that has been seen with clinical trials and other studies with high-risk patients. When we looked at prior BCMA therapy, which was primarily belantamab, which is an antibody-drug conjugate, patients with prior BCMA therapy, especially within 6 months of getting CAR T, had inferior survival outcomes. Again, this is not a surprise. When we give CAR T-cell therapy, we give chemotherapy to prepare the patient's body and bone marrow to deplete the lymphocytes. And typically it's fludarabine and Cytoxan or Flu-Cy, but there was a national shortage in 2022, and we had to use other alternative regimens, one of which was bendamustine. And we found here that patients who got bendamustine lymphodepletion had inferior progression-free survival and even overall survival, suggesting that fludarabine Cytoxan is the optimal preparative regimen before CAR T here. When we look at safety outcomes or side effects, cytokine release syndrome is a common side effect after CAR T, but the severe CRS only happened in 3% of patients. ICANS or neurotoxicity is seen in about a third, severe only happened in about 5% of patients. When we look at clinically significant infections, about half of the patients had clinically significant infections. And prolonged cytopenias beyond 1 month happened in about 28% of patients. Second primary cancers happened in 4% of patients, out of which second leukemias or myeloid cancers happened in 1% of patients. Importantly, there were no cases of any T cell cancers, which is the current topic of FDA review. FDA is reviewing all T cell cancers after all CAR T cell therapies that are in clinic for both lymphoma and myeloma and other heme malignancies. An important thing to look at with aggressive therapies is treatment-related deaths, where side effects lead to deaths. And this was about 6% with ide-cel. This is very comparable to what we saw in the clinical trial. And so to summarize, this is 3 columns looking at the data I just presented in the first column with 800 or more patients. The second column is the clinical trial data with the KarMMa data. And the third column is a real-world consortium study that I was privileged to co-lead, in which 11 different centers contributed data on standard of care use. And you can see the response rate and the deep response rates are comparable. And the progression-free survival is virtually identical at 8.5 to 9 months. And this is important. This means that this therapy, whether used in clinical trials or real world, has similar effectiveness and side effects, regardless of the setting that it's used in. So in summary, this is the largest real-world study of CAR T-cell therapy in patients with relapsed refractory myeloma. This was a very heavily pretreated population, and a majority of patients had comorbidities that would have made them ineligible for the KarMMa clinical trial. ide-cel demonstrated a favorable safety and effectiveness profile comparable to the trial population. And these results further support ide-cel CAR T as an option for a broad real-world population of patients with relapsed refractory myeloma. And so with that, I will stop and thank you very much for your attention.